time.
Be able to help you meet your mission, your purpose, your goals, and provide you specialized support so that you're not alone, and to be able to help you build, like I mentioned, collective impact work around your county in prevention planning efforts. As Barbara mentioned, we are funded by the Office of Child Abuse Prevention, so we work very close with our funder. OCAP is truly invested in supporting your county, and they're funding our organization to be able to help, to be able to provide that specialized TA. Next slide, please. So just to give you an overview of what we do, here is a slide that just gives you a representation of the work we provide and what we do with your counties. And this is the type of technical assistance that's available to you. Now, if you're currently not sure if you're eligible or not, or how do I sign up, just feel free to send us an email. We will work with you. Our contact information will be at the end of this presentation, but also I'll ask Bryn perhaps, or Barbara, if you don't mind, maybe sharing that information as well today or at this time, so they can have it for context. And so what we do is we help you with your planning and any support that you need to be able to facilitate the conversations within your county partners, to be able to ensure that we can support you with developing and strengthen your child welfare partnership. Make sure that you are aware of the CAPC, or Child Abuse Prevention Council, best practices. We have, as I mentioned, our team is very diverse. So if the consultant that's assigned to you does not have that specialized area of knowledge, we will bring another partner, another team member, another consultant to be able to help us. And we have subject matter experts in multiple arenas. And so today what we do is we're launching this learning exchange. We want to hear from you. Does this meet your needs? Is this something that you would like to add for the next session? Because the reality is we're doing this for you, and we want to make sure that you can take away a new tool, a new strategy that you can incorporate into your county. So we appreciate you being here with us. We also have webinars that are available, and our Strategies TA website has all the information. You can sign up. You also can follow us in multiple platforms, which we'll share during our session today. And also we do have a YouTube channel, which you can go back and look at some archive webinars. And then we also have regional and state gatherings, in which our goal is to have you connect with other similar counties or to learn from peers, because we truly believe in peer learning. And that is really what our ultimate goal is, to be able to facilitate multiple modalities or options for you to engage with. Next slide, please. So I want to share with you, as I close, a little bit more about who we are. We also have a framework in Strategies TA that our work really is in alignment with our core values. And our core values are spelled out on this slide, and that is that we want to make sure that we can look at accountability, that we want to make sure that not just we are accountable to you, but that we also are ensuring that the language and the understandings within your partnerships with your partners, accountability is one of the elements that will make a difference in the work we do in prevention planning. Equity, making sure that we have the ability to inspire and support counties to really reflect candidly and act on their local data and what the communities are asking or stating are inequities in their counties. Ensuring that community voice is at the table, that your planning has the element of residents, that community has an opportunity to be part of your planning efforts, to engage, to look at different modalities or strategies to be able to ensure that community input engagement is involved. Collaboration, we know that leveraging our partnerships will increase the resources that we have available to support our community. So really looking at collaborative efforts. And strength-based, looking at what you as an organization have to offer, what your team members have to offer, what are the assets that each of your team members partners have, and how do we bring those together to start looking at developing plans that allow us to leverage each other's strengths, resources, funding, and commitments to make a difference, to reduce child abuse in our counties. So with that, these are our guiding core values that we basically want to make sure that you know that that is what we work under as a framework, and our goal is to be able to share those core values within our work together. Next slide, please. So I'm going to go ahead and have Barbara take us to the next. area.
Okay, thank you, Lucy. So today our focus obviously is a learning exchange. And for those of you that were able to participate last November, we had a launch of Strategies TA, and we talked about all the different programs that Lucy described a minute ago. And we asked folks specifically, what are some of the areas that you would be interested in having learning exchange topics? So at that time, there were 5 topic areas that were identified. The one we're here today to talk about, child abuse prevention in rural communities. Also, there's learning exchanges that are going to focus on child abuse prevention in the time of COVID-19 and beyond, because as we know, we're going to move into a new normal. Building community resilience and community engagement, that's going to be another learning exchange topic area. And equity. And as Lucy mentioned, please make sure you're on our strategies mailing list. We have a strategiesca.org. You can go there and join. Then you'll know about these events when they're happening, and you can choose to join one or multiple learning exchanges. But one of the things that we really wanted to share with you today is, as a learning exchange, we want to develop relationships. So our hope is that we're going to come together as a group. We're going to learn together. We're going to learn from each other. Sometimes we'll bring in subject matter experts, like today we have a wonderful subject matter expert that you're going to meet shortly. Some learning exchanges may carry out specific tasks. So for example, maybe somebody wants to, a group wants to work on asset mapping together. So that's an example of a task that we could put together as a part of a learning exchange. And we want to create new knowledge. For those folks that came to some of the learning communities, there's a slight difference between learning community and learning exchange. One is the name. Learning community was a much more open setting where people could kind of come and go as they wanted. In a learning exchange, we're really hoping that we can bring a group together, that you can try to commit to attending as many learning exchanges as you can so that we can move forward, we can build our knowledge together. And the idea is that we're going to have 2 learning exchanges in this for this program year, which ends June 30th. So this is the first of the rural community learning exchanges, and the other ones are also going to be rolling out learning exchanges in the next few months. And so we'll have a second one in May, and we'll talk about that at the end of this event, hopefully planning for the next one, for the next learning exchange. But and then in the new year, we're looking at having 4 annually. So our year is a program year from July 1st until June 30th. Okay, next slide, please. So this particular learning exchange cohort, this is focused on prevention and learning, child abuse prevention planning in rural communities, because we know that California is an incredibly diverse state, and what works in Los Angeles County is not going to work in Butte County. And we know that the rural communities share a lot of the same challenges and the same resources. So as I said earlier, we can bring in subject matter experts. We hope that you, as a learning exchange member, because we want this to be member driven, you'll come to us with ideas for who you would like to hear from. We're hoping that as you move forward in prevention planning, you identify issues and problems and think, ooh, this would be a great topic for a learning exchange, and share that with us. And at the end of the event, when we at the end of our event today, we're going to hopefully have a few of you that might be interested in actually working with us to plan these events. And you can also share that in the evaluation as well if you're interested in that. We really want this to work for you guys, and that we're really facilitating a platform for you to come together and learn from each other. And we'll have time to talk about that later. And then next slide. So today, what we're going to do, We're welcoming you. We're introductions, challenges. We're going to hear from our subject matter expert, Todd Sosna, who's has a great presentation for you. We're going to have an open forum for questions and discussion, and we really hope that you will be willing to chat or be unmuted and we can have a conversation. We're going to take time to plan for the next learning exchange. So hopefully we leave here today with a topic selected for the next one that folks have agreed to. And then we're going to take time and you can do the evaluation either here or you'll get an email afterwards with the link to the evaluation, which we really encourage you to complete because the only way we can make this work for you all is if you feedback to us how we can make it better for you. So next I'm going to transition to Lucy, who's going to find out more about you folks.
Great. Thank you, Barbara. So let's hear a little bit now. We've introduced ourselves. We've introduced our commitment to supporting rural counties, but we want to hear from you. Who's with us today? And so I would love to invite you to please let's use the chat box for this activity. If you don't mind sharing your name, your organization, and perhaps share with us at this point if you're doing any prevention planning work in your county. If you are, share with us how is that going. Are you currently just starting a prevention plan, or is that something that is just being discussed, or we have not started, or we have it full in effect? Just share with us. If you don't have a prevention plan or you don't know if we have a child abuse prevention plan, just indicate, just let us know that at this point I'm not sure, you don't have that information, but share with us your name and also what organization you're with. And I did have a question that came privately. There was a question about if Strategies is available to support Southern California, and the answer is yes.
Yes.
We are statewide. We focus on all the counties in the state of California, and the goal is to be able to help. Currently, there are counties that they're actively working on their prevention plan. They actually attended a summit in 2019 that got them started on their action plan. And then we do have some counties that are currently working on getting to the place where they can start working on the prevention plan. But either way, feel free to connect us. Our website, like I said, and all our contact information will be shared with you at the end of this session, and feel free to connect and we'll work with you. Okay, great. Well, so we have, oh my goodness, we have several, thank you, team members here that are sharing. We have police department. Oh, wow.
Yeah.
Jeanette, Rochelle from OCA. And we do have several of our Office of Child Abuse Prevention team members here, our consultants.
Yay.
Jadish and Rochelle, I believe, are the two that I see. Feel free to join and say hello. This is a partnership, so just to let you know, these are our two consultants that we work with very closely. There's probably I imagine I'm probably missing another consultant that may be here, but we have so many registered. So if you are with OCAP, thank you so much for being here and supporting all the counties here in the state of California on prevention, child abuse prevention efforts. Perfect. So we do have several of our team members that are sharing
Tammy. I
from
see Tammy
Cap
Muldoon,
C.
Sierra. Yeah.
Alpine County Cap C. We have from Yuba County Office of
Hey.
Education. We have Sierra County Cap C, Hope Collaborative, and I don't know where Hope Collaborative is. Naomi from Hope Collaborative, but we have Stephanie also from Hope Collaborative. What county is that? Do we know? Oh, Riverside County. Okay, thank you.
Nice.
Jan from Humboldt, Cap C board. Elizabeth, Humboldt,
Oh,
Cap
Elizabeth.
C.
Mm-hmm.
Oh, perfect. We have Elizabeth from El Dorado. Thank you from the Cap C there. New Generations in the city of Long Beach, California. Perfect. We have Paso Paso program with St. Joseph's Hospital. Oh, excellent. Sheila Hernandez also from Hope Collaborative. We have a lot from Hope Collaborative. That's amazing. That's great.
Mm-hmm. Mm-hmm.
Wendy, again, she says, from Butte County, Cap C, Happiness, Cap C, excellent. And actually, she's actually going to start working on her prevention plan for Butte County very soon. So we're very excited to work with Butte County and support them. Donna is with Mariposa Safe Families. Oh, excellent. Mariposa County.
Yeah.
That's amazing. Mariposa Safe Families, one of the really great programs in Mariposa County. So I've had the opportunity to work with them. Leah Jones from Parent Partner Pathways. Sherry Sharon Hildebrand from CASA, the Director of Lake and Mendocino County. Thank you, Sharon, for being here. You've definitely made a difference in connecting us also with Humboldt County, and thank you. I'm sorry, Mendocino County. So thank you so much for helping us connect with Mendocino partners. Catherine in Trinity County, behavioral health, and wow, we do have a lot. So keep on sharing what county you're with. Oh, Angelica Paris from Children Interagency Coordinating Council in Glenn County. I have to just say props to Glenn County because I live in Glenn County. So I'm looking forward to meeting with Angelica soon, hopefully connect with her and support Glenn County. All right. So Bill Wathen from Glenn County, HSA. Bill, hello. Got an opportunity to work with Bill for many years. Amazing deputy director over in child welfare here in Glenn County as well. And we have Mono County Office of Education, Courtney Walsh, Mono Cap C. Wow. So keep on sharing your name, your agency, and we're going to do is I want to learn more about you, and feel free to tell us about your current experience with child abuse prevention planning. So we've actually posted on the screen, you'll see one. Give us a one if you're just.
Well, I think we have a poll, Lucy, don't we, Bryn? Yeah, we actually, Bryn made this a poll, so we
Oh,
can.
perfect.
Yeah.
Let's open up the poll then. Let's go ahead and just take a couple seconds to complete this poll. It'll open up here in a second or so. And feel free to just rate, where are you currently in your child abuse prevention planning efforts?
And Barb, I think because I made you the co-host, you might actually have to run the poll.
That's all right. I've done a few in my time.
There you go. All right. So tell us.
I've done a few polls, so I'm all right.
All right. So I'll give you a few seconds. We'll do 30 seconds to have you tell us about your experience with child abuse prevention planning, and we'll go ahead and read the results. So.
And if you're an other, feel free to share your status in the chat where you're at. We can look at that. We have 12, 17, 20. Oh, I'm pretty good. We got 54 participants, but there's some that may not actually.
And if for some reason the poll doesn't pop up because of, whatever browser you're using, or Zoom is just being difficult, please do type in at what stage you're at. Feel free to clarify a bit about your experience. We love hearing from you all.
Ooh. And what I love about this, and I'll close it in a second as soon as folks are done. We do have some folks that look like they have their plan complete, which is really nice. So those are our leaders. They're our experts. All right. Yeah. I think I'll end the polling. Okay. Share the results. Everybody see that? So we have a really good group here. We've got a group that is just starting out, a group that has a plan under development. We have some that are implementing. I love my folks that are honest and say, what is a plan? That is great. And then we have some other folks that are redeveloping, which a lot of folks are. Anyway, okay, great.
All right, Barbara. So thank you, everyone, for participating. This really allows us to just take a look at the landscape of the needs, where the counties are, and where we can support. So with that, we'll go ahead and pass it on to Barbara. Thank you, everyone.
So next slide, please. All right, so today our outcomes, we hope that you'll leave here today understanding what a learning exchange is. You'll understand some of the common initiatives underway with your peers that you work with. Learn how prevention outcomes can be captured and shared, and provide feedback for us to inform agendas for future meetings. And then hopefully some of you will say, yes, I want to commit to attending future cohort meetings. We know that your schedules are fluid. We know that you can't commit to everyone, but at least, if you say, that's my intention, that would really be helpful for us to get a feel for how many people want to move forward with this project. All right. Next slide. So today we're going to focus on providing tools and strategies to capture child abuse prevention outcomes in a rural setting and think about how to effectively share your story with funders and the community. And thinking about those specific pieces that make sharing your story maybe a little bit more challenging in some of our rural communities that might have a more conservative bend to the way folks are looking at child abuse prevention, because I do hear that a lot, that that's one of the challenges. And I just want to emphasize again that this topic came from you folks, folks that participated in our November event, as well as in our meetings with people throughout the state. This is how we came up with the topic for today. Okay, next slide. And when you registered for today's event, we asked you to tell us what are some of the specific challenges related to capturing outcomes for prevention planning. And I tried to put this into some categories, and we came up with 4 different categories that you were interested in. System level change. How do you measure systems change? How do you measure collaboration efforts and your CAPC effectiveness? That's something that's very challenging for you folks. Direct service level measures, how to measure specific program effectiveness, like a CASA program. I'm a CASA up in El Dorado County, so near and dear to my heart. Differential response, financial education programs, concrete supports where you're giving diapers and different things like that to families. How do you measure those outcomes? How do you measure prevention? Public outreach, Child Abuse Prevention Month, and then other things that sort of came under many different categories. How do you measure outreach activities? How do you measure whether or not your community has access to services that they need? And one of the things that I thought was really interesting was one of the areas that people mentioned was, how do you use population level child abuse data to inform prevention efforts, and how to use data to get on the same page? And further down, when we talk about topics, that could really be its own learning exchange. How do you use data, especially in counties like ours, where sometimes there's very limited numbers and limited data? All right, Lucy. Oh, before I introduce Lucy, I just want to say that I know that we all have been dealing with a lot of issues this last year and doing amazing, amazing things, and a lot of stress on so many different levels, social justice levels, issues with health and well-being of our families and our friends. So before we moved on to actually Todd's presentation, we wanted to take a moment, and Lucy's going to take us through an exercise on mindfulness. Okay, now we'll go.
Great.
Thank you, Lucy.
Thank you, Barbara. Well, as Barbara mentioned, this has been a tough year, and we have to recognize that it has provided a lot of challenges, not just at a personal level, but throughout the work that we do. Our community is in crisis. We are currently, as a nation, trying to heal through obviously a pandemic that we're facing, not to mention all the other elements that affect families that we're working with, affect us personally in our personal life. And in the work we do, we tend to give. We're putting out energy, we're putting out crisis, we're helping our communities, we are helping multiple individuals and residents that need our assistance. But we typically don't ask for help, or we don't ask for a timeout for ourselves because we're so busy trying to help others. So for this moment, I would like for you to go ahead, and if you don't feel comfortable being in a video, that's fine. You can turn off. But what I'd like for you to do is I would like for you to go ahead, and we're going to go ahead and just for a minute, we're going to disconnect. We're going to disconnect from everything else that's going on around us. So I'm going to ask you that I would like for you to go ahead and position yourself comfortably in your chair. If that means that you need to lean back or if you need to lean forward, I would like for you to go ahead and put your feet on the ground and make sure that you can actually feel the ground under your feet. I would like for you to go ahead and close your eyes. And I would like for you, as you close your eyes, to take a deep breath. Exhale. We're going to take another deep breath, and we're going to count for 4 seconds. And exhale for 4 seconds. Again, inhale for 4 seconds. And exhale for 4 seconds. I want you to continue doing this. Continue inhaling for 4 seconds. Close your eyes and continue as you exhale for 4 seconds. As you do this, I want you to start thinking about a memory. Maybe a memory as a child, maybe a recent memory, but think about a memory that brought you happiness, a memory in which you felt safe, you were joyful. I want you to just imagine yourself reliving that memory. As you continue inhaling and exhaling, think about that moment that you cherish so much. Imagine the weather, the environment, if it was maybe outside, what it looked like outside during this time that you're enjoying this memory. If you were inside, what does the place inside look like? Pay attention to the details, perhaps, that you recall from this memory. The scents. Do you remember if there was any scents? Maybe flower scents, maybe someone's perfume, maybe just that homey smell. Maybe someone was cooking at that moment. Just imagine the smells. And continue inhaling and exhaling. Now I want you to pay attention to how you're feeling. As you're assessing the environment, you remember the people that are around you that made this moment special. How are you feeling? Inhale and exhale. Now I want you to remember this feeling. And as you come back to the group, I want you to use this mechanism as a moment in which you may feel challenged, you may feel stressed. Take just a minute to just close your eyes and imagine yourself in that happy place, that memory. Maybe people that are no longer with us that you remember being with. Maybe loved ones that you haven't seen that you would like to maybe reconnect. But it's important for us to take an internal look at our own feelings, our own experiences, because we tend to always focus on trauma-informed approaches with others, but it is important for us to also know how we can take care of ourselves. And this is a tool that will help you whenever you're feeling challenged, you're feeling down. Take just a mindful moment to reflect on a happy time. And don't forget that feeling that I asked you to pay attention to. That's the feeling that will get us through this day. That is the feeling that will inspire us to connect with others, especially during these times. So thank you so much for participating. And don't forget that inhaling and exhaling is a really good breathing exercise that will help you just be present. So with that, I appreciate you taking this minute with me. And now we're going to move forward with our presenter. And I would like to introduce you to our presenter, which is Todd Sosna. Todd is our Chief Program Officer at the Children's Institute, Incorporated. He has worked in a variety of roles in both urban and rural environments. Let me share a little bit more about Dr. Sosna. Dr. Sosna is one of the largest, the Children's Institute Incorporated is one of the largest organizations of its kind in Los Angeles. using a 2-generation wraparound model to address the needs of children and families who have experienced significant trauma. Previously, Dr. Sosna has held an executive management role with large private nonprofit social service positions in agencies in Los Angeles. Prior to his work with nonprofit agencies, he has worked as the assistant director of Santa Barbara County Alcohol, Drug, and Mental Health Services, where he led their children's mental health programs, including the Multiagency Integrated System of Care, which is a national model of interagency collaboration. In addition, Dr. Sosna was a senior training, policy, and research associate, and later deputy director at the California Institute for Mental Health, which is a California based training center, which advances a broad range of statewide initiatives focusing on systems of care, peer support programs, evidence based practice dissemination, early childhood mental health, child welfare, juvenile justice reform, and outcome evaluation. Dr. Sosna, is we're honored to have you here with us today, and thank you so much for sharing your knowledge and expertise to support our rural counties in California. With that, I will pass it on to Dr. Sosna. Thank you.
Good afternoon, everybody. Nice to be here. These Zoom work group meetings are sort of interesting, so we'll hopefully have an opportunity for a little bit of dialogue, have it be more conversational. I think the learning exchange is really exciting. I've been involved in learning exchange type opportunities in the past, and I think they afford a lot of opportunity. As an initial meeting that focuses on outcome evaluation, given how diverse those of you on this meeting are, it's always challenging to find just the right level of information. So you have different projects, you have different sizes of projects, you have different evaluation questions that Barbara was summarizing into the 4 categories, the 3 categories plus the other. So today I'm going to devote some time to talking about outcome evaluation and some key issues that I hope is generally applicable. For some of you, you might be, well, that's something I already know. For others, some of the concepts may be more advanced. Hopefully there's something that everyone can take something away with. I think you'll see at the end the overall approach that I take when talking about this topic is that I think we tend to make it overcomplicated, and that the best advice will be to do some evaluation, and the more evaluation you do, the better you're able to support evaluation. And I think sometimes we overthink it, we overplan it, we imagine it's more sophisticated and requires a different level of expertise. And I think small counties are in a strong position to do compelling evaluation. And hopefully you'll walk away feeling the same thing. So I think I'm going to ask you to advance the slides as we go. Yes. So 3 focuses today: outcome evaluation in general, which is the most of what I'll talk about, and then demonstrating impact as a special small discussion, and what we know about what works in regard to program evaluation and prevention programs. Next slide, please. So my hope is that when we finish, you'll be able to walk away prepared to start using data, if you're not already, to have a process for clarifying impact within the context of your initiatives, and a context for deciding what makes the most effective, what are the components of the most effective prevention programs. Next slide. So outcome evaluation is divided into 5 areas: understanding your audience, choosing outcomes to share, collecting information, ways to measure impact, and analysis and reporting. And at the end, I have a number of examples under analysis and reporting from a variety of different prevention level initiatives, just to give all of us a flavor for different kinds of evaluation and how it can be presented in a compelling way. Next slide. Okay, purpose for evaluation. So sometimes evaluation is for the purpose of accountability. That is, we want to know that that a funder wants to know that what they've paid for has been provided. And that kind of evaluation tends to be focused on outputs. So I funded someone to do certain services, and I want to know the services were provided. So I'm going to set that focus of evaluation aside and talk instead about how we use evaluation to make decisions. And this is the more common and important approach to data. The idea is that outcome evaluation is going to inform some important decision or decisions about program design, about program implementation, about use of funding. And that always assumes a decision maker or makers and an issue or problem for which your data is going to inform those decisions. And I think sometimes this is overlooked. We're not thinking about the audience. So who's going to use the data and what decisions is my data going to help them make? So we make decisions all the time. Funders make decisions, program executives make decisions, direct service staff make decisions in the context of everyday delivery of services. And those decisions can be more or less effective. The idea of data is that helps us make more informed decisions. So when thinking about outcome evaluation, one of the things I think that's important to do is to think about who is your audience? Who is the decision maker? What decision are they responsible for making? And as a consequence, what information do you have available that will help inform or improve their decision making? Next slide. So different kinds of audiences. We're not going to go into this in great detail, although this can be a lengthy discussion in itself. Funders are audiences, board of directors and oversight groups are audiences, agency managers are audiences, direct service staff, clients or participants in programs, and consumers of academic research kinds of information. All are potential audiences and all would benefit from different kinds of information. So participants in our programs benefit from knowing what to expect. What do the services consist of? And what does my participation involve? And what is the likelihood I'm going to have a favorable outcome? Funders want to know if for a certain amount of money, what kinds of outcomes can I expect to get? Reduction in maltreatment, reduction in out-of-home placement rates, improvement in protective factors. If I'm an agency manager, I'm making decisions about the efficiency and the effectiveness of my services. So I'm going to need information that speaks to that. So outcomes are really determined by the audience and the decision the audience is making. And different information is more relevant to different audiences and for different decisions. Next slide, please. Okay, sharing of outcomes. What do you want to communicate? What do you want your audience to know? Again, the audiences that we were just talking about. What is the most important impact to share? And we're going to talk more about this, but sometimes we're trying to share everything we know as opposed to sharing one or two very important things to know. So our programs and our prevention strategies may result in numerous outcomes. We do not have to measure every outcome. We can measure key outcomes or gateway outcomes, outcomes that when they're achieved are related to other outcomes. For example, it's commonly understood that third grade reading level is a strong predictor of later success in school. So I don't have to measure every indicator of success in school. If I measure third grade reading level, that's a good predictor of how my academic programs overall are doing. And how can it best be communicated and understood? So when we think about sharing outcomes, we want to think about who's our audience and what decision are they making? What's the most important information to share with them? Not everything that's conceivable, not everything that I know, but what's most important in terms of the decisions they're trying to make, and how can I express it, communicate it in a way that makes it understandable and impactful. Next slide, please. So, tips on sharing outcomes. So I'm a strong advocate for simple and straightforward. Data shared drives interest in data sharing, which maybe sounds simple, but I've been in plenty of initiatives where people have spent a long time, sometimes a year or more, making plans for some kind of an outcome evaluation project while the very programs that they're providing are being delivered, only to have the outcome evaluation strategy be implemented somewhere in the middle of service delivery and then not being able to show compelling data. I've also worked in initiatives where individuals who are responsible for collecting and submitting the data don't want to collect and submit the data, or they don't submit it in a reliable and consistent manner. The strategy, I think, is the more you share data, the more people are interested in giving you data to share, because they see the reports, they see the impact, they want to be included, and they want their data as part of the larger data set. What you share may vary by your audience. You might want to share, in almost every case, this is the categories of data that people share. It might look different for different programs, but almost always it's information about participants, who you're serving. It's information about interventions, what you're providing. It's information about the impact. What did those interventions achieve? And information about how you collected your information and drew your conclusions so that others can understand the way in which you took data and informed decisions. And again, I think the strategy here is simple and straightforward. I will give you some examples, but only a handful of pieces of information are enough to complete a compelling report. Next slide, please. Some more tips on sharing of outcomes. So heavy on graphics and light on text. Who you served, what you provided, and how they benefited. Almost always, outcome reports can be very compelling with just 3 categories of information. This is who I served, this is what we gave them, and this is how they benefited. Quantitative information in a table or a chart, qualitative information in the way of a quote or a story, and in a single page, you have a compelling report about some activity that you sponsored or supported. Next slide, please. Impact. So this tends to be the thing that people are most challenged. How am I going to show my impact? How do I show an impact of a prevention program? How do I show an impact of an intervention program? So at the outset, I think you want to be thinking about what are your most important outcomes. And again, not everything that your services might do, but the things that are most important, the gateway outcomes. Secondly, what outcomes that can be achieved given your resources and the strength of your intervention. So this has to do with the correspondence between your choice of outcome, what you're trying to convince people you're doing, and the strength of your services. So, people might, sometimes we find ourselves in a situation where we're like, well, I want to prevent all maltreatment, but my intervention is a $50,000 parenting program. So you've got to choose an outcome that is reasonably achievable given the size of our programs. And sometimes I think we are looking at large outcomes with small resources and finding it difficult to show the correspondence. One of the strategies you might use is a snowball strategy, which is like when you pack snow together and you roll it down a freshly snowed on hillside. And as it rolls down the hill, it gathers snow and grows in size, which is more or less a thing that really happens. It doesn't usually look just like a ball, but a snowball will in fact grow as you roll it down a hill. So you can talk about an intervention that creates an impact that occurs shortly after your intervention that's modest. And then that modest impact is known to produce longer term impacts down the road, like that 3rd grade reading level. So that even if your intervention isn't strong enough to expect to achieve a big outcome in a short time, you can show that your intervention creates a small impact that's the core of that snowball that other research shows leads to larger impacts. Small savings account for children is known to be associated with higher income when those children are adults. So there are small things we can do, and we can show small impacts immediately that are associated with larger impacts known to develop over time, even though you may not be able to show that your small impact had that impact 10 years later. There's research to suggest that it's contributory. What are the ways in which important outcomes can be measured? So this becomes a key question, and I have a separate set of slides to talk about that. And which of these methods is practical given your resources? So when thinking about measuring impact, you want to be thinking about what are the important impacts? Is it reasonable to expect that those impacts can be achieved with the size and intensity of the activities you're supporting? How can you measure it if you do think it is? And do you have a way to practically measure it within the resources you have available? If you don't, then you go to your next best choice until you arrive at a choice that is practical, as opposed to fretting about an ability to measure an outcome that isn't practical. So you have to adjust your strategies. So we'll go down to the next slide. Okay, collecting information. So as simple as this sounds, this is sort of my computer's not working and the simple solution is reboot it. So some of these sound simple, but oddly enough, my experience is when talking to people, they've skipped the obvious. They're online and they're trying to upgrade something to their software, and and the solution was reboot. So what information do you already have? You probably already have information about participants or clients because they're enrolling in services. You probably already have information about what you provide: parenting classes, financial literacy, concrete assistance, case management, skills-based programs. That's 2 of the 3 categories of information that make up virtually every outcome report. You already have the data. Information about outcomes is the 3rd category. You may or may not have this data. Change in participant circumstances is an outcome. They have less money, they have more money. They were avoiding school, they're attending school. They struggled with parenting, they have improved parenting. Change in beliefs, change in attitudes, change in feelings, change in competencies, change in behaviors. These are all examples of outcomes. So if you looked at what you have now, my guess is that you easily have 2 of the 3 categories that you need. Do not have to go anywhere, don't have to have any new measures, you don't have to have any new strategy, and you may or may not have information about outcomes. You might not. If you have data about how often kids are reported for child maltreatment, if you have data about out-of-home placements, if you have data about school attendance, you might have lots more outcome data than you appreciate. Can we go one more slide? Collecting data. What does it take to collect data when you have to do it? Strong commitment to using data, some organizational capacity, and a concrete protocol that makes it easy. Use what you have, and what additional information you want, build into the natural flow of delivering services. As soon as you make it an add-on service, you decrease the likelihood it's going to be done. When it's embedded in the delivery of whatever it is your program entails, it's far more likely to occur. And just like information about who we serve, and just like information about what we provide is routinely collected, because almost always that's an obligation of providing activities, if you want outcome evaluations to be reliably collected, then you embed it into the protocol for delivering services. Next slide. Collecting information. You can collect it at a single point in time. So sometimes people think they need these very sophisticated strategies, need to hire a research psychologist, they need to be using SPSS, they have to have advanced statistics, I have to have an IRB, I have to get a consent form, I have to, have a control group. Okay, so there is compelling data that's collected at a single point in time. Now I'll give you some examples of this down the road. You can collect it prior to and after participation in a service or an activity. So some of the questions that came in advance of today's session was, how do I measure the impact of a specific intervention, like a parenting program? The best way to do that is to collect the data before the intervention and then again after the intervention. So it's pre and post. It can be collected on all your participants as part of everyday delivery of services. It can be collected on a sample of participants, and the results of that is as compelling and as accurate as if you collected it on everybody. I'm a big fan of sampling for systems that don't have the wherewithal to collect it on everybody. With a little bit of cautious sampling procedure, it's just as compelling. So sampling is a good way to get data. It can be based on what your client has to say. It can be based on what your staff has to say. It can be based on what's documented in your own charts. It can be based on what a third-party data sets that might be available to you. And I'll give you some examples. Why do I say this? Because we often think that it's hard to get it. So getting it from participants can be challenging. I can do a pre-measure, but then they don't finish the program. I don't ever get my post-measure. However, I can get completely reliable and valid data by having my staff complete the outcome measure. And I'm pretty sure that I can get my staff to complete the outcome measure if that's what they're asked to do. They're not going to drop out in the same way a participant in a program might not finish the program. I also have a ton of information I'm already collecting for other purposes that can be repurposed for outcome evaluation, because virtually everyone who provides services of any kind has something: who attended, enrollment information, information about their backgrounds, information about the services they need. And finally, I can use third-party data, and I'll give you an example of this that is might be the kind of strategy you'd use if you wanted to answer the question about were you affecting child maltreatment rates. Next slide. Storing data. So a sophisticated database is helpful, but not necessary. You can retain it in an electronic health record if you have such a system. It can be stored in a data warehouse if you have such a system. My favorite is it can be kept in Excel. And I will give you an example of a statewide evaluation that I was part of overseeing, where we collected data on over 10,000 participants and generated reports on a regular basis. And the entirety of it was done in Excel. Excel is completely sufficient for data storage. And you can keep it in hard copy files. So there isn't a single participant, I don't think, on today's meeting who doesn't have one of these available to them. Now, hard copies are possible. It requires a lot of manual work when you start to tally, but Excel is completely sufficient. Next slide, please. Ways to measure outcomes. So there are many ways to make use of data that can be illuminating and compelling. And by that, I mean they drive quality improvement and innovation. They inspire governmental agencies and private philanthropy. They motivate staff and build hope among participants. So those three statements actually crosswalk to the 6 audiences I mentioned before, right? So you can drive innovation and quality improvement. That's where you're trying to use data with managers of programs, executive directors of agencies. Inspire government agencies and private philanthropy. That's when you're looking at funders, motivate staff, and build hope among participants. One of my favorite use of data is when data is directed at participants, because we know that one of the things that increases likelihood of a good outcome is hope. And one of the ways we build hope is we let people know that when they participate in programs based on past participants, their likelihood of a favorable outcome is dramatically increased. It would be like if somebody had a medical condition and they went to get specialty treatment, and they were told that the treatment that was being recommended had a 90% success rate. That would inspire hope even before you start the intervention. We very rarely do this in the social service world, but we very frequently do this in healthcare. As a cautionary note, intent matters. So sometimes I've been involved with agencies who want to do outcome evaluation, but mostly what they want to do is they want to do evaluation that confirms what they already know. So that's strictly speaking not evaluation. That is marketing. It is self-affirming and it feels good. But evaluation necessarily means that you may or may not find that what you're doing achieves your intent, which is fine. Because if it's not achieving your intent, you want to know it and you want to adjust your programs accordingly so that they achieve what you want. So I just put this out there as we get into outcome evaluation. Sometimes my experience is, as I say, people are looking to confirm what they know, which is not the same as learning how their programs work. And it's fine to have an evaluation show an unfavorable result. That's information that helps us make adjustments. And if we're not open to the possibility that what we're doing is not working at the level we want, then we don't have an opportunity to support improvement activities. So no outcome is a bad outcome in evaluation. They have different implications. And I get that everybody wants the evaluation to confirm that what they're doing is working, but it's okay if it doesn't, as long as there's an openness to using that evaluation to make improving decisions. Next slide, please.
Todd, I just wanted to share that we got a text from Michael Burke from Shasta County saying that in Shasta, they measure hope using the validated hope assessment. So
I like
it's really
that.
cool.
Yeah, very nice. And there are many, many ways to measure concepts. I have yet to find a concept that can't be measured or an outcome, and almost always much simpler than people think. Ways to measure outcomes. A single point in time evaluation. When would I use that? If I had a single event, like a training, or I did some kind of a social marketing, like there's an initiative across California to prevent suicide. And so there's a website and a marketing campaign that goes with that. A one-time data collection would be appropriate. We would be asking, what did people learn? Were attitudes changed? Are people prepared to do something different? If I had an intervention, like a parenting program with a discrete start and a discrete end, then I could consider using a pre and post evaluation. Suitable for service providing agencies, change before and after participation in the course of services is what that would show us. Next slide. I can have an approach to evaluation where all participants give me data, suitable for when data is used in routine delivery of services. So for example, now when I go to my doctor, they give me the PHQ-2. Maybe a number of you have gotten this. This is 2 questions. It's a screening tool for depression, but it stands for a physical health questionnaire, which leads to the PHQ-9, same measure, 9 questions. And it's just routine now. They just give it to everyone who comes in for a medical appointment. So if it's part of routine practice, then you could use an all participants approach, quite compelling, or a sampling approach. When would you use a sampling approach? Suitable to evaluate the impact of a service or an intervention without having to involve all the clients and staff. Why would you do that? Because you don't have the resources, or because the measure you have isn't part of the normal flow of services. It's an additional measure. And you don't have the resources to ask everyone who's a participant in services to complete it. Or a qualitative evaluation, suitable for understanding a client's experience, exploring possible impacts and mechanisms. I often think that when people think about outcome evaluation, they're really only thinking about quantitative evaluation. But there is a role for qualitative evaluations, and there's a role for sampling and qualitative evaluation. So suppose, and I can have a mixed method approach, not meaning to make it overly complicated since I argue it should be simple, but suppose I collect something like the PHQ-2 on all my participants. And suppose I do it at the time they start in services and the time they end. And then suppose I use a sampling method to identify 10 individuals who were recipients of services, and I call them up and do a qualitative interview. I can't afford to do a qualitative interview on 100 people that are in my services, but I can do it on 10 people. And then I can put together an evaluation that highlights some data on everybody and qualitative data on a sample of people. And I end up with a very compelling story. The other thing I will tell you is that in my experience, the quantitative data, which everyone worries about needs to be rigorous, and ideally it is compelling, but it's the story, the one story about the one family that's not necessarily rigorous that seems to change everybody's minds. So there's the story of Mr. Rogers. And so the story goes that Congress was going to defund public television, and that, well, if you watch the movie, and then he speaks about how important, and he tells stories, and they decide to keep funding for public television. The point being, despite all the talk of rigorous evaluation, many decision makers are compelled by a single very compelling story. It's just, I guess, part of human nature that we value numbers, and we like to make decisions that help us make more favorable decisions. In the end, we also make decisions based on very personal information. Next slide, please. You can measure a variety of important impacts. I think that we are typically thinking of having to show some major impact and something hard to measure. And if that's where you're at, then back it up and ask yourself, what is a little easier to measure that's a good proxy for the thing that's hard to measure, right? So there's a lot of things that are good proxy measures that are easier to measure and that other research supports as good predictors of more significant outcomes. You can measure attitudes, beliefs, and intentions. You can measure feelings. You can measure behavior, competencies, living situations, right? So there's a bunch of stuff that can be measured, and it can be the very thing you're trying to impact, or it can be a good proxy for the thing you're trying to impact. It can be gathered in a variety of ways: ratings by self or staff, records of events, structured interviews, focus groups, third-party data. So there are many kinds of ways to get data and many kinds of outcomes one can measure. So if I wanted to know about the lead in a certain community, I guess I could draw blood from every individual who lives in a town and measure the lead content. That, I guess, would be the most rigorous and accurate, but probably not feasible. I could measure the lead in everyone's tap. That's probably also not feasible. I could sample a handful of people who live in a community, and I can measure the lead in their tap. That would be a proxy measure for the lead in their bodies. Or I guess I could take a hair sample and measure the lead in their hair sample, or a more rigorous measure of lead in a person's body, right? So there are different ways you can measure. They do not all have to be, you don't have to measure everyone and use the most rigorous way to have a compelling reason to believe you've impacted something important. Next slide, please. Analysis and reporting. So it can be simple and compelling. In fact, I have received these reports that come out from studies. They're 100 pages long, they're 200 pages long, and the likelihood they're going to be read is slim. What everyone reads is the executive summary. So why not make your whole report executive summary size? What would you say in your compelling, simple report? You would say, this is who we served. This is what they got, and this is how they improved. And I might include a little description about what we did and how we drew our conclusions. Next slide. This is my simple data set. As an example, 10 data elements. Ask yourselves, if I go through these, if these are things you already have. The date somebody is referred for a service, the date they first started the service, the contact, the last date they ever received a service, the total number of contacts between the first and the last date, their completion status, meaning it was favorable or unfavorable, how old they are, their gender, their ethnicity, and a target concern or relevant characteristic, the thing that brought them to you. A report to the child welfare system, or, a child who had been suspended or expelled from a school, whatever was the target concern. So I would guess that virtually everyone who provides a service, we'll come to primary prevention later, has all 9 of these data elements. What would we know with these data elements? Next slide. I would be able to know the entry rate. That's the percentage of people referred who start. Why is that important? Because we know that many people are referred for services, but many are lost before they ever start. And of course, if they don't actually start, then we can't expect any benefit. So the entry rate tells us how effectively we engage people. Completion rate, that's the number of people who start who finish. Why is that important? Because if you believe your service matters, then presumably they have to get a full dose of the service to get the full impact. And if people are dropping out before they finish, well, then you can't expect your program to be having its full effect. Information, I would know who's participating. I would know their average age, their gender, their ethnicity, and their target concern. So I could tell you something about who I was serving and how they corresponded to my larger community, which would give me an indication of whether there was any disproportionality across groups. Next slide. I could tell you the services I provided and the duration of services. 10 contacts over 3 months, 25 contacts over a year. And I could tell you the entry rate, the completion rate, the level of care, which is the number of service contacts and duration by gender and ethnicity. Therefore, I could tell you if boys or girls or people of different ethnic groups were entering at different rates, completing at different rates, and receiving different levels of care, all with the same 9 data elements. Next slide. So this is a sample report, although here, this page, the next ones will be easier to read. Then I understand you have this. This is the report I mentioned to you earlier. So this was being done when I was at the California Institute of Mental Health, and all of the agencies and the counties listed here were participating in an implementation of trauma-focused cognitive behavior therapy, which is an evidence-based practice for kids who have experienced trauma, commonly implemented across California. And if you turn to the next slide, I will show you just excerpts from the report. That was the introduction to the report. So information about who we served. So this is going to illustrate what I was just talking about. In this report, we had data from 15,979 clients who participated in trauma-focused CBT in one of the agencies or counties listed on the first page. All of that 15,979 clients worth of data was kept in an Excel spreadsheet. How old were they? On average, they were 11.2 years, 54% were female, 45% male. You can see African American, Asian Pacific, Caucasian, Hispanic ethnicities. And you can see that 25% of them had a PTSD diagnosis, 56% of them some other anxiety disorder, and 18% other. So this was in the context of mental health agencies, as it turns out. That the importance is not what you're seeing. The importance is the illustration of the outcome data. This is information about who we served. Every county, everyone on this call must have this basic information if you provide services. Next slide. Average length of service. On average, why 5,762 you see at the top, N? That's because those are the number of people who we had pre and post data on. So we had the same data pre and post. This was a pre and post data collection. On average, 33.6 weeks, ranging from 1 week to 156 weeks, an average of 27.2 sessions. So the average client received 27 sessions over 33 weeks, but the range was from 1 to 156 and from 1 to 311 sessions. Do not ask me about 311 sessions of trauma-focused CBT, which is only supposed to take about 16 sessions. Undoubtedly an outlier or data entry. It does happen. You see that plus and minus 16.7 and that plus and minus 15.2? That's standard deviation. So if you're more sophisticated and you want to show the mean and the standard deviation, which tells you about the distribution of the scores, because if you add 15 to 27, and you minus 15 from 27, that accounts for 2/3 of all respondents. That's how the standard deviation works. But suppose you don't know standard deviation and you don't want to bother with standard deviation. You can show range. Range is a good approximate of standard deviation. Standard deviation simply tells you how the scores are distributed around a normal distribution curve. Next slide. So entry rate and dropout rate. The entry rate was 98, essentially 99%, which means 99 out of every 100 children who were referred started. The dropout rate was 29.5%. So is that good or bad? I guess it depends on your perspective. 70% of kids who started finished. 30% of kids who started didn't finish, right? So those are the two things I was mentioning before, entry rate and dropout rate. It's a simple percentage. Next slide. So this is a more busy slide, but it has more simple and more sophisticated. This is an impact. The outcome measure is something called the YOQ and the YOQ-SR. So that's the Youth Outcome Questionnaire completed by parents and the Youth Outcome Questionnaire self-report completed by the child if they're old enough. What do you see? So the most simple score, parent and caregiver is the informant. Pre and post, there was a 39% improvement, that first upper left cell. That's based on 3,000 pre and post scores with a pre-score of 50. If you knew the cutoff on the YOQ, then you would know where that average score was relative to the clinical cutoff range, but you don't need to know the cutoff range. You could take that out of the report. That 39% is telling enough. But suppose you were very sophisticated, you could do something called an effect size estimate that tells you how large an effect that is. It's a 0.6 effect. That's considered a middle size effect size. Or suppose you wanted to look at it differently. Some of those kids got better. Some essentially didn't change. Their scores might have changed, but very small. It's like if I get on a scale in the morning and I get on the scale in the evening, my weight looks different. Have I actually lost weight or gained weight? No, not in a day, right? So you take out that variation, the change isn't real. And some kids got actually worse. Their scores got worse despite treatment. Okay, so 51% showed a positive change, 40% showed no change, 8% showed a negative change. Very simple way of presenting data. Do not need any statistics. That effect size is a rather complicated statistic. Don't need to have it to still be compelling. And that 39% is the most simple. That is the percentage of kids, that's the percent improvement between the average pre and the average post score. All of this, except for that effect size, done in Excel. I'm not going to walk through each one because, again, it's more important about illustrating, not about what we actually found. And this is about 10 years old, this data report. Next slide. I just like it because it's a good example. Here's graphic presentation. I don't even need that table. You see that horizontal chart? That is the cutoff score. If you're above that, you're in the clinical range. If you're below that, you're in the non-clinical range. You see that 51, that's the pre-score, and the 31, that's the post-score. And when the child did the self-report, 51 is the pre-score, 33 is the post-score. That is that 39% improvement. Even more compelling than any statistic, anyone can look at that and can say something happened that was favorable. Next slide. So the RAND Corporation did a evaluation for Los Angeles County's Prevention and Early Intervention Program. It's a mental health program. And do you remember when I showed you that statistic about kids who got better, kids who got no change, and kids who got worse? So there was this slightly more sophisticated logic that makes for a very simple and compelling presentation. You have some, and remember the cutoff scores. You have some kids who start above the cutoff, meaning they have a likelihood of mental health disorder, and some kids below the cutoff. They could be at risk, but they don't have a disorder. So kids who are above the cutoff, you want them to move below the cutoff. You want them to go from having a high need to being in the typical range. And kids who start off below can't move below because they're already below. But you want them not to move above. They're at risk, they are below, and you want to keep them below, which is the challenge of prevention programs. You actually haven't experienced the problem, but you're at risk of experiencing a problem. I want to prevent you from experiencing the problem. You're at risk of having cavities. I want to prevent you from having cavities. I'm going to teach you toothbrushing and flossing. I'm never going to show cavities if I successfully prevent you from having cavities. So I have a group of kids in kindergarten. I'm teaching them flossing and toothbrushing. Some of them already have cavities. My goal is to keep them from having any more cavities. Some of them have no cavities. My goal is to keep them from ever having their first cavity. That's what this shows you. The top list says 9 out of every 10 kids who were below stayed below. So these were all kids at risk, and 9 of them at post were still below. And 5 out of 10 who started in the clinical range, meaning they already had a cavity, metaphorically, no longer had a cavity when they were done. So it's a very compelling way to show a somewhat sophisticated concept, which I'm taking individuals who have a problem and showing the problem goes away. I'm taking individuals who are at risk of a problem and showing they never developed it. And that data is based on the very same 9 data elements I mentioned originally, because LA County happens to have emulated that report that I showed you earlier. Next slide. So under the Mental Health Services Act, the state of California implemented a statewide set of activities. One set of those activities was to reduce suicide. And part of that was to train people to understand suicide risk and to intervene. Ordinary people, not professionals. And so this is an articulation of their plan. We're not going to go through, but it is available if you have interest. Next slide. Also, it was evaluated by RAND. But one of the things they showed was attitude. So they did a training and they did a one-time data collection. And they asked questions about confidence to intervene before and after the training. Confidence to make a referral if they thought somebody was at risk. Likelihood they would intervene, likelihood they would refer. This was before and after a training. So it was just a one-time event. And you see the changes. This is not change in behavior. This is not change in suicide rates. This is change in people's understanding and confidence in doing something, which likely will influence longer-term suicide rates. But again, this is an example of a small change that they can take credit for that is likely associated with a bigger change that is the real focus of their strategy. Next slide. Here's the Know Your Signs. This is a campaign. The Know Your Signs. Maybe some of you have seen this. These are like the Know the Signs. Exposed to the no signs, not exposed to the no signs. So they asked people whether they were confident that they would intervene, one-time data collection. And then they asked them, had they seen the exposed to the no signs? If they had been exposed, the likelihood that they were confident in intervening increased. So they did a campaign. Then they called people up to find out had they seen the campaign and how confident they were to intervene. Does that make sense?
Can I just ask a question about that? Because I think a lot of our agencies do these kind of campaigns. How do you find the people you call? Like how?
They called people at random in the community.
Okay, so
Because
just.
the expectation is the campaign has a saturated effect.
Okay.
So if I called up 100 people and only one of them had seen the campaign, already I'm in trouble. Because how much impact can I have if no one's seen the campaign?
Right.
But let's say that half the people had seen it.
Mm-hmm.
Then I can ask a second question and I can say, oh, whatever. Did your belief, did your attitude, did your intention, is your confidence changed? And then I can show this. Half the people saw it, half the people didn't see it. But if they saw it, they were influenced. Give me a little bit more money and I'll expand it to the other half. I'll expand my campaign, right? It's compelling. Next slide. So this is the first report that I showed you came from the California Institute of Mental Health, which by the way has been renamed. They're now CIBHS, the California Institute for Behavioral Health Solutions. But the second reports I showed you were from the RAND Corporation and their evaluation of LA County's mental health program and the state suicide prevention activities. And this third set of reports comes from Riverside. And Riverside County Mental Health was doing 10 years of PEI. And they wanted to show that's prevention and early intervention from the Mental Health Services Act. Next slide. So that's just crediting Riverside. So point in time sample. They also had a kind of a campaign, just like you were talking about, Barbara. And they did a phone survey, and they asked, and they asked, had the ads affected their likelihood of being more supportive, make a personal effort, feel comfortable talking to, treat others. And this was in regards to mental illness. And you see the percentage of people who said yes, right? Very simple. They had a campaign. They arranged for somebody to do calls. It's a sampling method, and it's a one-time data collection. Next slide. Just like that trauma-focused cognitive behavior therapy, they have an intervention called PEARLS. It focuses on depression in older adults. They use the measure called the PHQ-9. It's a 9-item measure of depression, very commonly used pre and post treatment. It's exactly how they used it. And you see the improvement in scores from a 12 to a 4, rather significant and compelling. I don't have to tell you anything else for you to feel like that's meaningful. And they included a quote. This program has given me hope. I'm looking forward to my future, right? Very simple and compelling mixed method. Next slide. So this is an example. They were looking at a parenting intervention, empowering parents and increasing. So 4,930 total parents and caregivers were served. You see a quote. You see parents who were enrolled, the number that completed, that statistic I was mentioning before, something about the ethnicity of the participants, families that were enrolled in a very specific program, and that statistic, and then some general outcomes. Again, just a handful of information, almost entirely about level of participation. Next slide. And this is an intervention called Families in Schools. You see some percentages, you see some quotes, and the strengths and difficulties measure is a standardized measure of mental health functioning, and you see pre and post. Again, what I like about what Riverside did was they mixed some very simple quantitative information. You do not see any effect sizes. You don't see any standard deviations. It's still rather compelling. And the next slide, please. And then they did this very simple. So the report I'm taking this excerpts from is longer. And they were like, 77% of the time depression improved, 76% of the time trauma reduced, 70% of the time parent involvement increased, positive parenting increased, child behavior improved, and stigma reduced. They use different outcomes and different methods for each of those. And if you want and you're curious and you wanted to dig in, you could read the report and you would see. But now in a very simple way, which might be all anyone ever reads, is this, where they're saying 10 years out, we've collected data through a variety of ways, and this is what we know. Okay, next slide, please. And I know I'm moving through quickly. I've decided volume over depth. We have to have depth another time. So someone wanted to know about third-party data, and this is old data that I got from some training I did a couple of years ago. And I looked at the suicide trend. So this data is available from CDC. I just looked it up online. And you see the circles is the US, which is that kind of light blue escalating line. And the squares is California for the years 2012, 2014, and 2016. I would have made this look prettier, but I was taking it from some kind of Google search and I was having trouble making it work. And this is age-adjusted number of deaths due to intentional self-harm per 100,000. And I just went out and got this data and I said, well, look, in the US, suicide rates are rising over those years, and in California, it's more or less flat. And then I asserted that that may be because California does a number of things, including that Cal Mesa suicide prevention and all of the Mental Health Services Act funding. And people in California may not know that California has a very robust mental health system, but outside California, people are envious of California. All right, so do I know how to account for that? Maybe not, but it certainly suggests that something California is doing is different than the rest of the nation. So I went a step further. Next slide. I happened to come across an article in the Washington Post, and you see, you're going to flip between this slide and the next slide. So flip forward and back and back. So what happens is, yeah, this is 2005 to 2015, third-party data. This is not my data, but it is referential data. And if it's purple or blue, suicide rates are lower. And if you're orange or red, suicide rates are higher. So in 2005, everything from, I don't know what that is, just west of Texas to the East Coast is mostly blue and purple and green. And you see higher rates of suicide, not so much in California, which is purple, but all of the sort of like Nevada and in the surrounding area, Arizona. And then you go to 2015, and then you see how much more suicide rates elevate. And so you see lower suicide rates around the coast. California's has increased, but it hasn't increased as much as the rest of the country. So again, this is not my data. This is third-party data. There is third-party data on child maltreatment rates. There is third-party data on permanency planning rates and reunification rates and prevention program rates. So you don't always have to have all the data, nor do you always have to collect all the data to make a compelling case. Next slide, please. Data use and culture. So if you're not doing much evaluation and you're going to do more evaluation, then here's just a handful of things to bear in mind. One, value data. Sounds simple, but I know plenty of places where people are like skeptical of data and it seems like a bother, not a help. Creative and undaunted by barriers. If you can't get the data you want, get the very next kind of data. So if I see that piece of fruit on the top of the tree that looks so ripe and I'm desperately wanting it, but I can't reach it, but there's a piece of fruit a little lower on the tree. It happens to be already visited by a bird or something. It has a little hole, but it's within my reach. So, don't always insist on getting the pristine piece of fruit. Sometimes you have perfectly suitable data within your reach. Share data reports often. The more you share data, the more people will want to use data. Focus on the practical, not the perfect. A little data collected and analyzed with integrity and shared frequently is more impactful than a lot of data that's inconsistently collected and rarely reported. And I have been involved, and I'm sure all of us on this call have been involved in plenty of efforts where we were required to collect data and submit it to the state or some funder somewhere, and we never saw a report as a result. And that leads people to think that there's not much value in data collection. So better to collect less and use it often than to collect a lot and never see a report. Next slide, please. Now I'm segueing. You can't tell, but the background of the slide is green. This is the extent of my sophistication with PowerPoint. So all the previous slides were about outcome evaluation, and you will see they correspond to the 5 topics, and the headings of the slides are color-coded to correspond to those topics. So demonstrating impact, this sort of big question. So a handful of considerations. Clarify your destination. Sometimes we fail to be as specific as I think we need to be. And the first question is, what are you trying to achieve? And who will achieve it? So all initiatives are like trips, like vacations. And there's always a destination. You cannot expect to measure an outcome if you, for example, how much is my trip going to cost me if I don't first decide where I'm going and how many people are coming along with me. So if I say to you, tell me how much your vacation is going to cost you, I don't know how to answer that unless you know if I'm going to Hawaii or Alaska or, Europe or wherever I'm going. And am I going by myself or with my family or with everyone at my work, right? So you need to clarify where you're going and who's getting there. So who's the focus of your prevention activities, and where are you trying to move them? From what point to what point? Second, clarify your strategy. How will your program, how will your prevention activities, how will your participants reach their intended goal? What strategy, what is the way they're going to get there? And ask yourself, is the strategy strong enough? If your strategy is not strong enough to get people to your destination, then you're focused on the wrong destination. And a lot of times we do that and we're disappointed. So your destination has to be within the reach of your strategy. And then clarify signs of success. You do not have to prove that people reach the destination. You only have to show that there were signs that they reached their destination, right? So I don't have to necessarily, if my program is about preventing maltreatment and my strategy is to improve protective factors, if I show protective factors are improved, that's what I'm taking, holding myself accountable to. If the research shows that people with higher protective factors are less likely to experience maltreatment, then I can build on that, just like the suicide data I showed before. So I can look at some macro data and I can show protective factors. So you want to look for signs of success. How would I know I was there? Okay, next slide. You may want to know if you are preventing an adverse event, and this is the challenge with prevention, is you're stopping something that never happened. I like the cavities, because good toothbrushing and good flossing is about preventing cavities. So no one has cavities. So how can I take credit for that? Right? So I have to know what it would have been like if people weren't brushing their teeth and weren't flossing. How would you know if rates of child maltreatment were decreasing? How would you know if your programs were responsible? So there are two questions here. The first question I could probably answer. I can't think of a single county who can't answer the question, are rates of child maltreatment, or at least child abuse reporting as a proxy measure, increasing or decreasing? It's harder to know that your program was responsible for that. You may want to know if you're building protective factors like financial resources and social support. How would you know if protective factors were increasing among recipients of service? Probably straightforward. You could use a measure like this protective factors measure, commonly used, easy to do. How would you know if increasing protective factors resulted in less child maltreatment? Harder to do. However, if I put those two together, it's more compelling. If I know that child maltreatment rates are falling in the very same window of time that protective factors were rising, I can make a compelling case that the two are linked. They may not be, I don't know for sure, but I can make a compelling case. And so this is an example when I say in prevention programs, you have to measure things that you have the ability to measure, and you want to hold yourselves accountable for things that your interventions could realistically achieve. That doesn't keep you from saying something meaningful about something larger and more robust. And then if we switch, we're just at the tail end, what we know. So this, by the way, pink is the third topic. Just so you know, there is logic here. This is what we know about prevention programs. We know that you want to intervene early and you want to continue to provide supports over time. Because when we intervene early, we improve outcomes. However, sometimes we stop providing supports and those gains diminish as children get older. So the research suggests intervene early and continue over time. We want to be comprehensive. I happen to be a big fan of two-generation models. If you're not familiar with two-generation models, the Administration for Children and Families is a proponent of two-generation models and is the federal agency that funds child welfare, right? So Title IV. And the Aspen Institute's Ascend initiative is a two-generation initiative. And it's simply whole child, whole family. So being able, the best outcomes are achieved when we work with children and their parents. So we work with, systems involved kids often have systems involved families. Kids who experience trauma, often their parents as children experience trauma. And if their parents haven't had the opportunity to recover from their own childhood experiences, they're ill prepared to support their own children. And so two-generation approaches address that. Build assets, the research says build assets, financial assets, social support assets, interpersonal communication and interpersonal skill assets, and educational assets. And finally, use research to inform your strategies. Lots of evidence-based practices to build upon. So essentially, the most effective prevention programs start early and continue or have some ability for people to get supports over time, are comprehensive, whole child and whole family, build assets, and are based on research-informed strategies. I think that is my last slide. Yes, it is. And I know that was a lot of material. Hopefully it gives you a feel for how outcome evaluation can be done, and hopefully gives you a feel that there's no limitation simply because you're small. However, you do need to think about, who's your audience? What are you trying to inform? What do you have available? And how can you create a compelling message? And there are many, many ways to do it. And they don't require research psychologists. I happen to be a psychologist, but I'm not advocating for research psychologists having to be used, nor does it require a sophisticated database, nor does it require sophisticated analysis and statistics. It requires a compelling narrative and an openness to the results that allows for thoughtful decisions to be made. So hopefully I left some time for questions.
We have one.
Okay.
Michael Burke, who does the HOPE assessment, asked the question, he's from Shasta County, do you think we need an outside source to do our evaluations, or do you think we can do it ourselves?
It can be done both ways. If you have the wherewithal and you want to engage an outside source, there's nothing wrong with that. I've seen that done very successfully. However, it's also possible to do it in-house. In either case, you need to have somebody, whether it's an in-house or external, who has this as their focus and who engages in a process not unlike what I was just walking through. So what are you evaluating? What's the destination? That kind of thing. I think that, so I think it can be done either way. The agency I work for, Children's Institute, it's a nonprofit agency in LA. We have a research and evaluation center, and it's staffed with 12 full-time research associates. We evaluate every one of our programs, about 36 government contracts, from Head Start to child welfare to mental health related programs. However, I worked for a different nonprofit agency, about a little smaller than Children's Institute, and they had no research. They had no research in-house capacity. So this is one of those things that people decide they either are going to do or they aren't going to do. We have quality assurance people, that's routine. You have finance people, that's routine. You have HR people, that's routine. If you value research and evaluation, well, then you hire a research and evaluation person, and it just fits like everything else that you do that's, that's part of the agency's overhead and administration and quality improvement. I've seen programs partner with universities. I've seen them hire people right out of college to do these roles. They're not necessarily highly compensated. They're not poorly compensated, but they don't have to be, excessively compensated positions. The strategies we're talking about for effective evaluation do not require research training and expertise. Hopefully what I'm sharing with you is that it's common sense. I want to make a decision. What would compel me? What information do I value in making a decision?
Yep.
Right? It's
That's
the
great.
clarity about who I'm communicating to, what I'm trying, what decision they're responsible for, and what is the minimum information they need to make a more informed decision. Does that make sense?
I like the idea about partnering with the university, and because a
Yeah,
lot of our
I've seen
agencies
that.
don't have the capacity.
When I was in Santa Barbara, I was with the county mental health system then. We partnered with UC Santa Barbara.
Yeah.
At Children's Institute, we have co-applied for research grants with UCLA and USC, which of course are local universities to us. Riverside uses UC Riverside. So there are, right, I mean, there isn't anyone, right? There's, in every community, Humboldt has a call, everybody, I'm looking around who's on the call, everybody has a university or a college and somebody you could partner with. They might apply for funding on their own. They might do it as a collaborative project because they're part of the community. There are lots of ways to bring expertise in. I think the key issue is clarity of thought.
Yeah.
As opposed to all of, we're so busy worrying about the technical aspects of the evaluation when the real meaningful part of it is the clarity of thought. And then you will find in almost every case that you have the information you need. You just haven't put it together in a way that's compelling.
Thank you very much.
Yeah.
Excellent. Bryn, could you move up? I think we're going to go 2 slides, right? Because I think we're good with, in terms of the open session. We get any questions that came in, and then if there's anything else, as we move forward. But we wanted to spend a little bit of time thinking about topics for the next learning exchange. And I'm really pleased. There's so many people left on the call. We want to end at 3. So what I'm going to ask you to do is 2 things. Make sure you fill out the evaluation. Let us know if you are interested in working with Lucy and myself in planning learning exchange programs. Again, we want them to work for you. But then also, if you would chat in the chat box, if you have an idea, if you could just put that slide back up. I'm sorry, Bryn.
Yeah, a topic idea that you're interested
Yeah, the topic ideas.
for the next
It'll be
learning
one
cohort.
so that I can share the link to the evaluation.
Oh, okay. Bryn's going to share the link to the evaluation, and then also the topic ideas that you folks previously shared that you were very interested in from either November, or some of the things that I pulled off your registration were reaching remote and isolated families and reducing stigma and building trust. I hope that rings a bell to somebody. Working with less, this is a separate topic, resource limitations and wearing multiple hats, which I think folks would recognize yourselves in that. And again, these are topics to explore in another learning exchange. And then how to use population level child abuse data to inform prevention efforts, and how to use data to get on the same page. So those were 3 topic areas that were already suggested. If you have other ideas that, excuse me, oh, now they're up. Thanks, Bryn. If you have other ideas that you are interested in, post them in the chat. And what we'll do is in the next few days, I'll put together a survey monkey. We'll send it out and we'll ask you to vote on your topic of choice. And then that's how we'll decide the next topic for the next learning exchange program. So if you take a little bit of time, just think about that. What would be a topic you would be interested in? These are 3 ideas, but you may have something else. Maybe something that, Todd spurred with his conversation, maybe, learning more about Shasta County's use of the HOPE assessment. Whatever you might be interested in, chat it, and we will put together a survey monkey, and we'll get that out shortly. And then Bryn just posted in the chat the link to our evaluation. So we'd love for you to take a moment, excuse me, if you click on the link, you can do the evaluation now, or you will get an email shortly after this event, and you can do the evaluation then. But the evaluation will ask, how did you like the event today? How could we improve it? But also it asks if you'd be interested in working together with Lucy and myself to plan another learning exchange, and also if you have ideas for another learning exchange.
And if there's a topic that is, as Barbara said, on the slide, and you feel like that is something that you would like for our next cohort, just put either number 1, 2, or 3 on the chat box so that we know that that's something you're voting for. Or like Barbara said, if you have any other topic, especially because we want to make sure we create these learning exchange cohorts for you. This is the goal, is to provide as much information, bring subject matter experts in the areas that we need resources in rural counties. So let us know. This is made for you. And I just want to say again, thank you, Dr. Sosna. That was
That was
amazing.
great.
I'm here taking notes, and I got my highlighter, and I just I really appreciate how you made this. There's a lot of information, and I agree with Mariposa. A lot of information, but what really stands out for me is that we don't have to overcomplicate the data. If we could just have that simple checklist that you gave us of those, 5, 10 things that we can decide as partners that we're all going to collect, it really allows us to have a discussion, and it doesn't complicate that we're not collecting enough information, but we can start building some simple data elements, and that allows us to start growing and expanding in other areas collectively, so that we can provide, maybe apply for funding together,
Right.
because we're all collecting the same information. So thank you so much, Doctor.
Yes.
That was really helpful. And I hope that you found the information useful. If there are any questions that you still are thinking about, write them in the evaluation. We will make sure we send them to Dr. Sosna, and then we will send it back to you as a response. So once again, let us know, what are you interested in? Our next learning exchange cohort, Barbara, is on.
Yes, it is on May the 25th. Let me make sure that's correct, because sometimes I get a little confused on dates, but I'm pretty sure May
Yes.
the 25th, and that is a Tuesday, and it's going to be in the morning from 9:30 to 11:30.
And so we hope that you can put this now on your calendar, save the
Mm-hmm.
date, and the topic will be coming out shortly based on your input. We really ask that you take a minute of your time to fill out that evaluation. It really helps us develop a learning cohort that really speaks to you. We want to get your input, and our contact information also, Bryn will put it up here as well. Please take a note. Feel free to take a snapshot of it, a picture. If you need our contact information, we once again encourage you to connect with us, learn more about Strategies Technical Assistance. Obviously, we're funded by the Office of Child Abuse Prevention. We're here to serve you. And, any questions you have, we have a team, and we look forward to bringing some resources to your county.
And I also wanted to just say, if anybody did not receive the PowerPoint, I mailed it out on Friday. And if somebody registered like over the weekend or just popped on this morning and you need me to send it to you, please email me, bdgraph@thecapcenter.org, and I'll get that out to you right away. And I agree, yes, one of the things that we're going to work on for our next learning exchange is more time for exchange and maybe breakout groups. I see that as a comment. That's a great comment. And looking at, and thank you, yes, for the folks that are voting. That's great.